Hello and welcome. My name is Alice, and I'll be in the background answering any Zoom technical questions. If you experience difficulties during this session, please type your question into the Q&A. We also encourage you to submit written questions at any time using the Q&A. The chat panel will also be available for comments and feedback. During today's event, live closed captioning will be available in English and Spanish. You can find the link in the chat field. With that, I'd like to introduce Paula Barberia, Chief Quality and Medical Officer and Deputy Director of the Quality and Population Health Management Division at DHCS.
Thank you so much, Alice. And everyone, welcome to our December meeting of the Quality and Population Health Management Advisory Group. We can go to the next slide. So as a reminder, I think all of you on this call probably are aware of this already, but our continuous coverage requirement for Medi-cal enrollment that had been put in place as a part of the COVID-19 public health emergency ended on March 31st, 2023, which means as of April, Medi-cal members are undergoing redeterminations, many of whom for the first time in 3 years, many of whom have never had to do this before. Our explicit goal is to make sure that everyone who is eligible for Medi-cal coverage stays on Medi-cal coverage, and anyone who is found to be ineligible is covered to another type of health insurance coverage through Covered California and elsewhere. You can click on the links below and get an update on all of the announcements and access toolkits and communications messages that you can use in your communications with Medi-cal members. We can go to the next slide. And most importantly, I will guide you all to the new Medi-cal continuous coverage unwinding dashboard, which releases really helpful critical data, including at the local level, to see how many members are meeting, redetermination requirements, how many are being disenrolled for procedural reasons. And when you look at the data, you will see there are many opportunities to better support and inform our members throughout this process to make sure that they are keeping a lookout for their redetermination packets and submitting them in a timely fashion, as well as updating their contact information. And the bottom two websites you'll see are member facing, so please feel free to get the word out. You can go to the next slide. So I'm really excited that today for our Pop Health Advisory Group meeting, we are going to do a follow-up deep dive on our proposed population needs assessment policy as a part of the Pop Health program, which many of you got a preview of several months ago. We have guest speakers from our MCP local health jurisdiction collaborations that have been happening across the state for CHAS and CHIPS. We'll then go through a recap of what the 2023 policy was for the population needs assessment that our managed care plans have been working on in partnership with public health, and then do a deep dive on the forthcoming requirements for 2024 to 2027 PNA policies and upcoming guidance and technical assistance. And then mostly we want feedback from all of you, first and foremost from our advisory group, but also for our attendees. We have an open chat as always. Your feedback and comments in the chat will really help us strengthen and refine this policy before it is finalized and published later this year. We can go to the next slide. So we are now going to jump into our guest speakers. So I am thrilled to have Dr. Phuong Luu and Barb Alberson joining us today for this part of the conversation. I'm going to have both of you introduce yourselves and your role, and then we'll go through a few questions that we have for you.
Okay, I'll go first. I will not go first. Go ahead, Dr. Luu.
Hi, good morning. My name is Phuong Luu. I'm the health officer for Yuba County and Sutter County.
And I'm Barb Alberson. I'm interim health director here in San Joaquin County Public Health.
Fantastic. And if it's okay, maybe we can take the slides down so that we can spotlight and see our speakers as we're having this conversation. So I'm going to turn it to both of you, and you guys get to pick who wants to go first. We're hoping that you can provide a 1 to 2 minute overview of how your current public health community health assessment and community health needs assessment process is working in your county. And maybe actually, Barb, let's start with you since you had volunteered to go first earlier. It would be great if you could provide an overview and history of the process, including stakeholders involved and data shared, as well as how different stakeholders have contributed resources.
Okay, then. Hi, everybody. In San Joaquin County, we call it CHNA, since our nonprofit hospitals have to call it that under their IRS regulations. It's always made common sense to us to work together to co-produce one countywide CHNA and CHIP. In our three managed care plans, which is Health Plan of San Joaquin and HealthNet and Kaiser, participate very fully in their development. All three plans contribute to the cost of hiring a process consultant, serve on the core team, which does the day-to-day decision-making, and in facilitating the meetings of our 50-member community steering committee, which is all our community partners throughout the county. All of our nonprofit hospitals and our FQHCs also are core team members and with the same level of collaboration. In terms of data sharing, my public health epidemiology staff do the heavy lifting there. They compile and analyze the quantitative data. We base our work on the Healthy Places Index. And this cycle, my EPIs pulled indicators, ready for this, for more than 20 different data sources. Garnering qualitative data is shared by all of us with the support of our consulting firm. For example, outreach residents for a community survey, all the key informant interviews, and the focus groups. Significantly, and I'm sure this is true statewide, what has not been routinely in the mix is follow-through. More clarifying language in the guidance would help to provide a clear path to assign resources to help not just plan and do the reports, but implement our CHNA and our CHIP strategies. Our nonprofit hospitals do this routinely using their community benefit dollars.
That is a hard just follow up. I can't follow up with that, right? This is just amazing. So we're not as good as San Joaquin County. In terms of Sutter County and Yuba County, for the first time in many years, we initiated a robust child CHIP process. So I do want to clarify that even though I serve two counties, they have very distinct processes. So the child CHIP process for Sutter County completed in June 2023. We had 3 health priorities of addressing homelessness, reducing the burden of sexually transmitted infection, and building resilient community. And then once we were able to complete the CHIP, we published publicly the dashboard across all 3 health priorities. And then based on the population health management guidance issued out by DHES, we did meet with both incoming medi-cal managed care plans, Partnership Health Plan, and Kaiser medi-cal, and we called out specific strategy that they can assist us with in terms of financial support for our project manager to stand up a behavioral health learning collaborative, because one of the key need from our community was called out is navigational services, that people really didn't know what insurance even they have, where to go based on in-network providers, any specific telehealth options. So we're very excited and we're waiting to hear back from our MCP partners in regards to that request, financial request. On the Yuba County side, we're a bit behind Sutter County. So we completed our child CHIP process in September 2023. But as part of the CHIP process, we had also 3 health priorities: healthcare access, mental health access, and safe neighborhood and built environment. And we broke it into 3 different work groups. And so knowing that Partnership Health Plan was entering very soon as of 1/1/24, I took it upon myself to email their chief medical officer and their behavioral health administrator and ask for representation at the work groups for both health priorities of healthcare access and mental health access. And they provided a lot of great input, and we are in the process of drafting a very similar financial request for Partnership and Kaiser for Yuba County.
Thank you both so much. Clearly, there's a spectrum of experience. And Barb, as you said, this makes common sense. So we're excited that the rest of the state is finally catching up to what you all in San Joaquin County figured out some time ago. So you both hinted at this, but Barb, would love to hear a little bit more about some of the ways in which this combined CHNA process has helped improve community health and strengthen relationships in San Joaquin County.
I think the one element that I'd like to share with you today is what we call our priority neighborhood profiles. These are the heart of our CHNA and speak to our shared commitment for both health equity and for collective impact. It takes a very deep dive into data that defines just 14 of our disadvantaged census tracts that suffer the greatest burden of disease and injury, and also the negative conditions that impact health. In true terms, we just threw away service areas. We all focus and align our resources to be more powerful to help these neighborhoods thrive. For example, we've aligned funding to work on improving unsafe and neglected parks in 6 of our priority neighborhoods. Also, many of us have used this approach to successfully compete for extramural grants. For example, public health was successful in garnering a 3-year, $3 million CDC community health worker grant. And we share that with 6 of our CBOs. And the reason I think we got this grant is because we were deploying our CHWs to work in 1 or more of the priority neighborhoods. They got it and they understood what we were talking about.
Thank you so much. Phuong, would love to hear you talk about the advantages of looking more upstream and taking a more holistic view of health.
Sure. It's because we only see one facet within each of our lenses, right? For example, let's say a Mr. Jetson, he might have syphilis, but also homeless and also on medi-cal and has type 2 diabetes. So from the public health standpoint, we see him through the lens of syphilis management. From a social services standpoint, we will take care of his housing needs, and then his frequent visits to the ED, interacts between the MCP and of course the hospital care. But if we take a step back and look all the way upstream of it's actually the same person. It's one Mr. Jetson, right? So how do we share information in a timely manner so that we deliver whole person, high quality care that is timely to this individual? And really that is the only way that we can move the needle in providing good health care to all of Californians. So the community health assessment and community health improvement plan really is community. It takes a village, like the cliche, but it's not just through the lens of public health patients or healthcare specific patients or even MCP beneficiary. It's that it's every one of us. So taking a global view is very much necessary to move that needle.
So I think we all know that, at the end of the day, when we get to brass tacks, a lot of it is about resources and having sort of the funding and bandwidth and people to do this work at the local level. And so, Barb, would love to hear a little bit about, how the managed care plans that you've been partnering with have contributed to the community health assessment process that you've been doing, and how the modified sort of P&A requirements are, trying to get us to this future state. What have you seen as the value of aligning this process locally, and what's the value for MCPs who've been partnering with you?
Well, here's my professional opinion. It's terrific value. A special note when we're talking about aligning processes, I do need to share with you that local health departments who are or are seeking national accreditation are to do their CHNA every 5 years. Our nonprofit hospitals by IRS regulation have to do it every 3 years. So all of us together decided we will do it every 3 years. So it's copacetic for our hospitals because they're one of our major funders. So that's why we do that. But it works out great for us. But every 3 years, not every 5. Since I'm not, I think the best way to respond to this is to say we try and answer the what's in it for me question. It maximizes resources for sure. It reduces redundancy and absolutely reduces duplication. The MCPs have their P&As, nonprofit hospitals have their CHNA, health department has a CHA, and also even our first 5 commission has to do an annual assessment. So I can't imagine if we each had to do it separately, especially if we're talking about the fact of trying to avoid getting in each other's way when we're garnering input from the same community stakeholders. The approach has another nice dividend, though, because it also lends to a better understanding of how we each operate and what our constraints are. For example, I can talk HEDIS measures, and my managed care plans can tell you all about the public health, social, ecological model and social justice. So I'm being a bit facetious, but it really does allow us to blend our talents and our expertise in a way that we might not have otherwise.
Thank you so much, Barb, for really sharing how you're bridging that chasm in real time locally between public health and healthcare that exists throughout our entire nation. Phuong, same question for you. Would love to hear sort of what you think the value is for MCPs to participate, and also how you've started collaborating already with MCPs for the SMART goals and for 2023.
Yeah, so I want to echo everything that Barbara just said. She has said it so eloquently. How we have approached it in terms of Sutter County, Yuba County, because we're a bit behind San Joaquin County, is that we really emphasize it's not a one and done. Right, so it's not just participate in completion of the CHA or completion of the CHIP, but it's always iterative. So now we're in the implementation phase. So we really make a point to communicate the what's in it for MCPs to participate with us in the successful implementation of the goals, objectives, strategies, and actions spelled out within the Sutter County and the Yuba County CHIPs. And then we're going to do it again, right? So in a few years, we're going to reassess where we're at, and we need MCPs to be at the table because, yeah, we need their HEDIS measures, but they also need our expertise in terms of population health expertise. We're very, very proud in terms of local health jurisdiction that we truly are the population health experts.
So final question from me for both of you is, what does success look like in 10 years if we really get this local collaboration between MCPs and public health, and ideally nonprofit hospitals right?
Well, LOL. As I shared, we've been collaborating on the CHNA and CHIP process for probably 25 years. So for us, it's just growing more of the same. This winter, we're going to start our next 3-year cycle. And again, I anticipate that we are going to address root causes with a very strong health equity lens. And that has actually caused a little bit of disconnect with what the population managed care plan has to do. It was a bit of a slog for us to find a SMART objective that worked for us because, as I say, we dive deep on root causes, and your DHCS directives were pretty medical model. So finding the connect up, and what we did was, I'm pretty pleased about it, and I think it'll be a process that continues. It's not going to be a one of, but that is that we focused on mental health, but the managed care plans will be doing the depression screenings, maternal and adolescent depression screenings, and of course follow through with mental health services when it's a clinical issue. But we all know that depression and anxiety and chronic stress have to do a lot with life issues. For example, the car won't start, you have a kid who's truant, there's no daycare. In all of those cases, the managed care plans will do a warm handoff to public health, and we will convene our community partners to help address those community needs. And we see that going forward, getting stronger and better and more concerted as we go through it. So we just hope that your targets at DHCS will give us a little bit more wiggle room going forward in terms of what meaningful participation actually is.
Thank you so much, Barb. And I will just acknowledge on behalf of the department that we recognize the way we measure quality using largely HEDIS and corset measures is very sort of medically driven, often far too downstream. And so we too are eager to learn through this process to see how we all can evolve together to really think about that holistic, upstream, whole person based approach.
Beautifully said. Thank you.
In 10 years, I just want to be where San Joaquin County is already at. right? But to take a step back, I think this is very much an opportunity to align priorities and reduce redundancy. There's so much need, and if we're disparate in our focus or we're doing duplicate work, then it actually makes us less efficient, right? So the alignment of the PNA, the CHA-CHIP, the CHNA, and even potentially other health assessment is going to ultimately be helpful for our community, which we all serve. It's the same patients, the same beneficiaries, the same clients, however terminologies you use, whether it be to healthcare, public health, or social services. So when we align, we can do much better for our community.
Pavla, can I just say one more thing? Of course, Barb always has to say one more thing. I'd like to see the guidance reframed just a bit. As Dr. Lewis said, and I've shared, we're not starting from scratch in many communities. So I would like it to say to initiate or to strengthen ties, because there are quite a few counties that have been working hard on developing and strengthening ties with their managed care plans. And this is a wonderful step forward, but it's not always starting from scratch.
We really appreciate that edit. And I'm certainly taking away how avant-garde San Joaquin County has been for the last 25 years. So Barb, we're going to be asking for your phone number, and I'm sure I'm not the only one who wants it. I'm going to lift up one question from the chat, and then I'll open it up to our advisory group if any of you have questions for our panelists before we move on to the next section. So Diane Dooley in the chat is asking, will your public health departments be participating in the statewide data exchange framework? Why or why not are you participating?
So Sutter County, Yuba County, as of yet, have not participated. We are not a required signatory. However, we are looking into it. I think there's quite a bit of unknowns, right? Even for the required signatories, the data exchange will just start beginning of next year. So we will see how things go, but we are keeping close monitoring of it.
You know, I'm being facetious, but seriously, it's a little bit of a watch and learn.
Great. Advisory group members, feel free to just take yourselves off of mute or raise your hand if you can't unmute for some reason if you have any comments or questions.
Hi, this is Michael Day with Children Now. Appreciate the conversation and was curious, Barb, I think you had mentioned warm handoffs, and as those relationships get strengthened and there's more folks referring and more warm handoffs happening, what challenges do you foresee in that being successful and effective for families?
One of the things that's useful for us, so we have a connected communities network. I don't know if all of you are familiar with that, but we have a closed referral system. About 80 to 90 of our community partners, of all public and private partners, are part of that. So we have a referral network that is in place that we all use. So it won't be quite as complicated sounding as it might seem at first blush.
Rob, go ahead.
Yeah, hey, Rob Oldham from Placer County. Just wanted to say mainly thanks so much for the presentations, Barb and Dr. Luu, and thanks to, because I think we've been talking about better aligning the CHA and CHNA processes for many years. So kudos to the DHCS team and actually a lot of people on this call, not just from DHCS, and finally kind of moving the needle a little bit on better alignment. I know, yeah, IRS and the Public Health Accreditation Board, I know they had some incentive for each of our entities to do our respective assessments, but I think this will really some of the efforts under CalAIM will help make these much more closely aligned. I guess my question is thoughts about how we can evaluate this, and appreciate having flexibility with, I believe, 61 different health jurisdictions and lots of different hospital systems and a lot of different health plans across the state, having some flexibility in how we do this, but thoughts about how we can evaluate the integration of the respective assessment processes to see how this is going, and maybe evaluate and look back a few years down the road. Thanks.
Great questions. I don't know that we're going to answer all of them today, but that's a perfect segue. Actually, Karen, let's take your question, and then I'll tee up sort of our next section.
Well, thanks, Pallav. I really appreciate also the presentations today. Thank you both so much. And I was excited, Barb, to hear about the funding that you got for community health workers in your area. Two questions. One, for Phuong is, to what extent are you looking at, leveraging community health workers and, local allied professionals in, in the community health needs assessments that you're pulling together? And then just maybe a broader question about the way that both of your counties are doing the community health needs assessments. To what extent, what does the governance structure look like for those? How are you working, with CBOs and community leaders to decide on the interventions that and where to apply for funding for various interventions that you land on? Thanks.
Well, let me flip it. Your second
Go
question,
ahead, Barb.
answering the first one. Sorry, Dr. Lou, did you want to go? No. The governance structure is very clean. There is a co-lead. It's the public health department and one of our healthcare systems. So for right now, it's actually three. There's Kaiser, Dignity Health, and Public Health are the co-leads. And then we have a core team made up of the funders, and there's 12 different funders right now. Everything from our County Office of Education and our First Five Commission to all of our nonprofit hospitals, our FQHCs, and our Medicaid managed care plans. That's the core team that does the day-to-day decision-making. During the development of the project, we meet every other week. We have a standing call. Sometimes it's only 10 minutes, but we direct what the consultants will do. They take their directives from us. And then we have the steering committee, which, as I said, is 50 plus members. And they only meet a couple of times because they agree to and understand that we can do the day-to-day stuff. But when we need to prioritize, when we need to develop our ranking, that's where we go to them. And then when we develop our strategies, they develop the strategies. So it's co-leads, core team, steering committee, but we take our direction, to tell you the truth, from is community led. So what the community tells us they want in our focus groups and on our surveys is a lot of times what we decide to make as our priorities. And then on CHWs, that's a whole nother conversation, and you can't answer that in 5 minutes, but we have many different sources of funding for CHWs, and trying to network them all and ensure that it works with CalAIM as well as with the other sources of is a work in progress, but we're pretty excited about it. But it's definitely a work in progress.
So we have a very similar process to San Joaquin counties. So initially with the community health assessment, we did a very large community survey. For instance, on the Yuba County side, we had 996 just general survey, and then we did key informant interviews and a focus group, and then we gather all that rich quantitative and qualitative data and brought it back to the entire community. So invited more than 90 key stakeholders to come, presented the data, and we presented our list of recommended priorities, and then they voted. And then we say power of three. Since we only have 3 to 5 years, please let us know what you as the community think should be the 3 health priorities. And that's what rose. healthcare access, mental health access, and safe neighborhood and built environment. And then afterwards, we broke each of those health priorities into specific work groups. And each of those stakeholders were able to volunteer for one or maybe even all three work groups. And they, within those work groups, decided on the goals, the objectives, the strategy, the actions. Some of them would raise their hand as lead entity. So we heavily emphasize that this is community-led, community-driven. This is not a public health plan. It's not a hospital plan. It's a Yuba County plan. So we are the convener, the facilitator of the process within Yuba County Public Health or Sutter County Public Health, but it's really very much requires the entire community. I'll happy to put in the chat the public-facing dashboard for each of our health priorities, just so you can see what I verbally went through.
Thank you so much, Phuong. I'll just add an editorial comment that sort of the community-led process that you both described is so critical to the vision that DHCS also has for health equity and how we get there, and really thinking about how we power share and lift up community voices to drive the, both the county's interest, but also the medi-cal policy forward is of great interest to us. There's lots of comments and lots of questions. I do want to move us on to the next section, but Michelle, let's take you as a final comment, and then I promise there'll be more time for dialogue.
Yeah, thank you, Phuong. I do, just as I see some of the comments in the chat, want to round out the understanding of like what this is, right? Local health departments have been doing child chip processes without promise for funding, right? This has been really around planning for their communities. I think what the great benefit is that the hope and the goal is that management plans will help partner with us in moving the needle forward and in those strategies of the CHIP. But this has not been like a process where as a jurisdiction does this, all of a sudden there's like 10 new funding streams to invest in all of these new different things, right? And so they've been doing it with the very limited resources we have, and the hope is that this will move the needle forward. It also is not, at least on the health department side, right? It's not incumbent or our ability to approve or authorize what types of like ECM and community supports that are then invested in. It can help inform that if a plan so chooses, but it's not where the health departments now have resources to invest in these things. So I just want to make sure that we're keeping that conversation at the forefront, that this has been a tool for local health departments to figure out what are the strategies, and they've been doing what they can to move the needle in those strategies forward. But I'm starting to sense in some of the questions about like, is this a funding source for CHWs or for ECM investments and things like that? And that is not necessarily what this piece is. I just want to level set that.
Really great flag. Thank you so much. Okay, so we're going to put up the slides and go through the next two policy sections, and then we'll definitely have some time for Q&A and the robust dialogue that we're hoping to happen. So we can go to the next slide. So to recap what happened or is happening in 2023. So as you all are tracking, in January of 2023, the Population Health Management Program went live. In May, we released a concept paper about what this potential could look like, where managed care plans really join and partner with existing public health, community health assessment processes. You all got a presentation of that and provided really helpful comment and feedback. And then in August, we updated our policy guide and APL language to really lay out what plans should be working on for 2023. And we required plans to submit a planning worksheet to us in October, which was really how they were coordinating with their local health jurisdiction, meeting and discussing areas to align largely around DHCS's Bold Goals initiative, which you heard our panelists talk about briefly. We can go to the next slide. And then in 2023, our plans were required to submit a strategy deliverable, which again was really about, are you meeting with your local health jurisdiction? As Barb was mentioning, in some areas, this is a robust partnership that has been present for many years, and the folks are working on strengthening it. In other areas, this is really a first-time effort. And then we also know with the new plans that are entering and exiting medi-cal as of January 1, 2024, there's also new partnerships and collaboratives that need to be set up to accommodate that change. And so as a part of that, plans are required to submit what they are working on with their local health jurisdiction, and then also to meet NCQA requirements, plans have to have a membership assessment and a population health management strategy that they submit to NCQA. And so plans that are already accredited have sent that strategy into NCQA, and then plans that are not are sending their strategy to us. We can keep going. So now this is sort of the new stuff, which we are previewing you all for the first time. And I just want to acknowledge this is not just a DHCS effort. There's really been tremendous partnership and collaboration across the state. So huge shout out to our state partners, HCI and CDPH, as well as to CCLHO and CHIAC, who really provided invaluable, feedback, expertise, and partnership to hopefully bring this vision to reality. So we wanted to cover what the proposed requirements are for managed care plans for 2024 to 2027. We can go to the next slide. So some of this got so complicated that we needed to put it on a timeline. And so the ultimate vision, I think, as Rob was alluding to, some of this can be really complicated. We have 61 local health jurisdictions across the state. We have plans where in, some plans, they are covering 20, 30 counties across the state. We have other counties that have up to 5 managed care plans that they have to work with. And so one of the pieces of feedback we heard loud and clear from almost all the stakeholder comments we got on our concept paper was that there needs to be some sort of strategic alignment to get everyone across the state onto the same cycle and rowing in the same direction at the same time for this to really work, and to allow both managed care plans and local health jurisdictions to really, go all in on this partnership. And so the current policy is predicated on that between 2024 and 2027, if a local health jurisdiction is conducting a community health assessment, the plan will participate in that pre-planned existing community health assessment process. This also allows all local health jurisdictions to be on a glide path with the vision that starting in 2028, the entire state is on a 3-year cycle for community health assessments and CHIP submissions, and that we stay on that 3-year cycle, forevermore, and really allow everyone to coalesce. So the goal for this would be that the first sort of statewide community health assessment that would be done in every single county and local health jurisdiction would happen over the course of 2028. With the community health assessment portion of the process being done by the end of 2028. And then everyone would have about 6 months to turn that around into the deliverable. So for local health jurisdictions, that 6-month writing process results in the CHIP. For managed care plans, that 6-month writing process would result in a population health management strategy deliverable to the department. And then this timeline loosely, though not perfectly, aligns with nonprofit hospitals as well. Although, as mentioned earlier, their timeline is dictated by the IRS and when their tax filings are. And as we have learned, some of those vary from hospital to hospital as well. We can keep going. Actually, can we go back one slide? I just wanted to lift up a comment in the chat. Is CDPH also mandating this timeline? So I think our CDPH colleagues are on the call. I don't know if you want to take that question and then talk about the timeline from your perspective. Trudy, I don't know if you're having a hard time taking yourself off of mute. We can help unmute you if you want. Okay, we will come back to our public health colleagues as we can work out their tech issues. And Alice, maybe you can connect with Trudy offline to see if she's having issues unmuting herself. You can go to the next slide. So now we're going to do a deeper dive into what these requirements actually mean. So as I alluded to, the PRIME plan must participate on the CHA-CHIP process for every LHJ in their service area. And so the PRIME MCP is the managed care plan that has a contract directly with DHCS. And when we say every LHJ in their service area, this includes sort of not just all counties they serve, but also those cities that have their own LHJ. So if they are operating in that service area, they are expected to participate in the community health assessment process. And yes, for MCPs that span multiple counties or cities, that means they will be participating in multiple CHAs and CHIPs across the state. Although, again, once we get to 2028 and there's a more consistent timeline, we hope that there will be opportunities for partnership and scaling and organizing that effort. For any prime MCPs that are covered by a subcontractor, they are included in the PNA process. So the prime managed care plan will be figuring out how their subcontractors contribute resources, participate in the process, but there will not be a separate deliverable. The deliverables come from the prime managed care plan that holds the contract with DHCS. And then we definitely heard also in public comment and from our local public health colleagues loud and clear that when there are multiple managed care plans in the same service area, it is really critical that, there isn't sort of siloed conversations happening. So if there are multiple MCPs in the same service area, for example, 5 plans in a certain county, the managed care plans must collaborate with each other as well as with the local health jurisdiction so that there is a unified planning process. There will not be siloed planning processes with each MCP. And then managed care plans in that scenario must also coordinate what types of investments they provide so that that is shared and communicated with the LHJs, again, to sort of make the most of this collaborative opportunity and not duplicate resources or efforts. Go to the next slide. So in-kind staffing and funding. So we are strongly encouraging all managed care plans who are a prime managed care plan to allocate resources to this process for all of the service areas in which they operate. Starting in January of 2024, they'll be strongly encouraged to work with the local health jurisdictions to figure out sort of what that support looks like, whether that is funding or in-kind staffing. And then starting in January 1, 2025 is when we would strongly encourage managed care plans to effectuate that funding. So 2024 is really sort of a planning year. And then 2025 is when we would expect that investment to be made. And then plans will also be required to report directly to DHCS, at least annually, how they are contributing these resources. And that will be part of the deliverable for the population health management strategy deliverable. And then you'll see here, these are sort of, the types of funding that in the comment letters and stakeholdering that we have done that have been needs that have been identified. So things like administrative support, project management, data infrastructure, community engagement, all of these have costs. And as Michelle Gibbons pointed out earlier, there isn't sort of new funding streams that come along to really effectuate all of these processes for the most part. And then in-kind staffing may also help support or augment some of this actual funding to meet all of these needs. We can go to the next slide. The other big piece that came through in all of the public comment letters is really data sharing. And so, I think there is general acknowledgement, and we heard from our panelists concrete ways in which this is already happening on the ground. But managed care plans and local health jurisdictions each have really incredible, valuable data, most of which is from different perspectives. And so there's definitely data that local health jurisdictions have that is informative to MCPs, and then really rich data that MCPs have about medi-cal members that they serve that can really help inform the local community health assessment. And so between 2024 and 2027, MCPs are expected to begin data sharing with local health jurisdictions in ways that support the CHA and CHIP process. I will also point everyone to the boilerplate memorandums of understanding that are also rolling out with the new 2024 medi-cal managed care contracts. Also have provisions for data sharing, and the population needs assessment is explicitly also identified in there. So this is not an entirely new requirement. This is really building upon some of the foundation that we've been laying with the new contracts. And in 2024, we will expect every managed care plan for each of the local health jurisdictions in which they are operating to identify priority areas where they will start sharing data. And then starting in 2025 at the latest, the actual data that has been agreed to must be flowing from the managed care plan to the local health jurisdiction. And then since MCPs are required signatories of the data exchange framework, we will expect them to be following the provisions of the data exchange framework when sharing data with other LHJs that are also signatories. As you heard, LHJs are not required to be signatories. And so for ones that are not yet signatories, that will not be a requirement. And it looks like we have figured out the technical issues. I'm going to turn it over to Rudy, and if we can go back to the timeline slide to just talk a little bit about the public health expectations on this.
Hi, good morning, and apologies, Pallav. I was having some technical issues, so had to log off and log back in. But to the question about local health departments, so the intent is that, as you can see here, during 2024 through 2027, that will be kind of a planning and ramp up period, because we know that many of the local health departments are either having completed their CHA, in the process of completing their CHA, or even going through an update of their current CHA. So we want to make sure to provide for a ramp up period with the intent that starting in 2028, that LHJs will shift to that 3-year cycle to line with the MCPs as you see here. And we are working really closely too with HCI on, because we know many of you are also working with your not-for-profit hospitals on their CHNAs. So we are also working really closely to see how that happens as well. But again, we want to make sure that there was enough of a planning period between 24 and 27 with the intent that LHJs then align in starting in 2028.
And then while we have you, Trudy, I'm going to turn one more question to you. Laura Salcido is asking, will the new 3-year cycle requirement be approved by FAB? And we know that, as you heard from our health plan of San Joaquin, San Joaquin County colleagues, they've been on a 3-year cycle for some time. So there are ways of meeting it. But Trudy, I don't know if you want to talk about FAB more explicitly.
Absolutely. So it does, within the 2022 reaccreditation standards, it does say that CHA collaboratives can choose a cycle that is less than the 5 years, and they do use 3 years as an example. So, and even dynamic CHAs are also acceptable to FAB, where folks use kind of like an update to a website and things like that, and constantly updating the data. It's more about the process for FAB. So as long as the data is updated every 5 years and it's dated by 5 years, absolutely acceptable to FAB that LHJs move to a more frequent cadence.
Perfect. Let's get back to the data slide. Great. And I also saw some questions in the chat about sort of demographic data that will allow us to stratify this information. So yes, that can be a part of the data that is exchanged depending on the local needs and what their focus areas are. We can keep going. So I think that, we recognize that in some areas, these partnerships, as mentioned, are really nascent. In other areas, they are much more robust. And so really starting in January 2024, as is already captured somewhat in the MOU, but building upon that, managed care plans will be expected to attend key CHA and CHIP meetings as requested by their local health jurisdiction partners, also serve on a CHA or CHIP governance structure, including subcommittees as requested by their local health jurisdiction partners, and then also really engage their community advisory committees as a part of this process. And so for those of you who are not aware, with the new Medi-cal managed care plan contracts effective January 2024, every single Medi-cal managed care plan is required to have a community advisory committee that, again, is really designed to strengthen that community voice and engagement within the process of dictating Medi-cal policy and provision of services. And so MCPs will be required to report on their involvement in and findings from this joint CHA-CHIP process to their community advisory committees. They will be asking their community advisory committees about input and advice on how to use these findings to influence managed care plan strategies, work streams related to a whole host of services, inclusive of bold goals, wellness and prevention, and health equity. And then over time, also work with LHJs to really use the Community Advisory Committee as a resource for stakeholder participation in the CHA and CHIP process as well. And then plans will also be required to publish the common local health jurisdiction version of their CHA and CHIP on their websites for all service areas in which they operate, as well as the brief summary, of what their goals are. And then I also saw, I just wanted to lift up, there was a question about sort of the bold goals and are they sort of, limiting if we want to get to a true community voice. So I would just say, Hannah, I think in talking to our public health partners and looking at a number of CHAs and CHIPs, most of the conditions that the bold goals cover really are around maternal child health and mental health. And I would say most of those conditions are present in almost every single CHA and CHIP that I've seen. That was also sort of a slight interim strategy for 2023. So I think as we get to the statewide aligned approach by 2028, a lot of that is likely going to change as we get into a more uniform process across the state. Catherine, I see your hands up if you want to make a comment on this slide.
Sure. Yes, just a quick question with regards to the community advisory committees and the intersection of the MOU quarterly meetings that we will be having with the local health departments. And this in addition to the CHA-CHIP planning meetings, do you guys really see this community advisory committee separate and distinct from those MOU planning discussions or those quarterly required meetings, or are they one and the same?
I think we'll probably need to take that question back and dig into it a little bit more because that policy straddles a few different teams at DHCS, but thank you for raising that.
Yeah, thanks.
And then I also see a question about Kaiser. And so yes, the new Kaiser direct contract sets the same expectations for Kaiser as every single other medi-cal managed care plan. It is a common managed care contract. So the 32 regions counties in which Kaiser is operating will also follow the same format. Okay, we can go to the next slide. So this just gets a little bit more into the detail about how we want to start digging into understanding and ensuring that managed care plans are really building these relationships in during this critical planning period and phase up period between 2024 and 2027. And so managed care plans will be working with their local health jurisdictions to complete this worksheet by August 1st of 2024. And the managed care plan will not be submitting this to DHCS, but we may be reviewing it if we have concerns or questions and want to do a deeper dive. And so the worksheet is really, again, to start figuring out where are their pain points, where are things working, where are things not working, and to really guide technical assistance. So a lot of this policy that we've reviewed today is about the community health assessment process. We know that that's not the end of this process, right? The community health assessment really just identifies community needs, and then those needs are turned into an action plan. And so there still is a lot of work across our state departments, with our managed care plan partners, with our local health jurisdictions to figure out, how are these entities working together, not just for this part of the process, but then for the implementation pieces that will be coming down the road. And we fully intend to think through technical assistance that we can provide at the state level to managed care plans and LHJs, both for the assessment process that we're talking about, but also for the implementation process thereafter. And then to reduce the burden on LHJs, if there are multiple MCPs working with a single local health jurisdiction, we expect a single worksheet to be submitted as a demonstration of that partnership and commitment. We will not be getting 5 worksheets for the 5 plans in that county. We can go to the next slide. And then, so that worksheet is due in August of next year. In October, plans will be required to submit their annual population health management strategy deliverable to DHCS. We have not released the template for that deliverable yet. But again, there will be one population health management strategy deliverable per local health jurisdiction in their service area. So if you're, in 32 service areas, there will be 32 deliverables. And then if there are other MCPs working in that area, MCPs will need to collaborate to submit a single shared population health management strategy deliverable. And we've listed here some of the things that we will be expecting, but again, a template will be made available in the spring with more specific requirements. But mostly we'll be checking in on how the collaboration is going with local health jurisdictions, what progress has been made to the SMART goals that were identified this year, really a description of how community needs are being centered in this process, and then any updates to the NCQA Pop Health strategy, and any other relevant updates. And then someone had also asked about evaluation. So obviously, I think the long-term goal would be to really understand how these local partnerships drive improved outcomes for the community, including health outcomes, but also others. In the short term, we are going to be really laser focused on how is the relationship and trust and partnership going. And so in addition to having managed care plans submit these deliverables to DHCS, we will also be conducting a survey directly with local health jurisdictions to get all of your feedback on this process and what the partnership has been like from your managed care plan partners, so we can really make sure that this new process is working for everyone. We can go to the next slide. So upcoming things that are coming down the pike, we will be updating the policy guide with a lot of sort of these requirements that we just previewed today by the end of the year, so that managed care plans know what the expectations are. And then next year, sort of statewide technical assistance and clarifying guidance will be provided to really set managed care plans and local health jurisdictions up for success for the child CHIP process as we're in the glide path years between 2024 and 2027. We can go to the next slide. So maybe we can take down the slide so we can see everyone. And then I'm going to ask our MNAC colleagues to maybe field questions and send them our way. And, you know, my public health and CCLHO and CHIEC and HCI colleagues, please feel free to join in as well, as you've been a critical part of developing this policy.
I was on double mute. Can you hear me? Yes, okay, thanks much. Okay, thank you. We're getting some great questions. And so one of the questions that, some of the questions have are around what's going to be public. Are the worksheets going to be public? Are the strategy deliverables going to be public? And the worksheets, again, are sort of an internal collaboration tool. But Paula, do you want to speak to any consideration of whether these documents will be made public?
Yes, I think the worksheet won't be collected by DHCS, so can't comment on that one, and not sure that that would make sense to be made public. The joint community health assessment, which is sort of, and the CHIP, which are the products of this joint collaborative, are already public and posted by our local health jurisdictions, and plans will also be required to post that same document on their website. And then we can definitely take the feedback about the population health management strategy and whether or not that is required to be posted publicly, as we're still working on the guidance, and we'll be releasing more detailed guidance on that front next spring. So thank you for that suggestion.
Great. And then just questions about the information that we've provided today and the guidance provided, including details on how MCPs and LHJs should engage with CACs. And so when will we be releasing guidance related to all of that?
Yeah, so as always, the materials in our advisory group today are pre-decisional, so they will be posted publicly, but they are not final policy, and we will be incorporating, based off of today's conversation and final feedback from stakeholders, these details, Kim, to your question, in the revised population health management policy guide, which should, we are hoping to finalize the guide this calendar year, so in 2023, in the upcoming weeks. How quickly we can get it, remediated and posted to our website may bleed into the first few weeks of January, but it should be out pretty soon within the next month.
Great. This is a question, and perhaps it's for Phuong and Barb, but there was a question about how community leaders, providers are actively involved in seeking funding for community change. I'm not sure if you want to talk about your perspective around that. It's particularly related to the CHIP process and how they've been involved there. But yes.
We're still in the very nascent stages there. And I do want to lift up what Michelle Gibbons highlighted. The most of the time, we have tried to implement the strategies and action called out within the CHIP with no funding. And so we're really, really excited to align with our nonprofit hospital partners and our MCPs so that we can have now new sources of funding. But I think it's also now clarity of, say, a new grant would come up and then we're like, okay, yes, this makes sense for Yuba County or this makes sense for Sutter County. Let's collectively apply for this because our community tells us this is a priority. And like Barb said about her community health worker grant, that was awesome, $3 million in CDC. It just really provides clarity of why we and where we need to focus.
Yeah, I can't state strongly enough that we take it out of our hide. It's more about people giving their time rather than funding available. We do go after grants, and we've been lucky enough to get a Robert Wood Johnson grant here called Build Health, and an ACT grant from PHI. So we cobble it together, and you just have to have that work now for payoff later. What we do have, which is a wonderful dividend, is that our nonprofit hospitals give us priority in their community benefits grant funding. So Kaiser and Common Spirit, now Dignity Health, and Sutter Tracy, they've all used their funding, and Adventist Health as well, to help guide some of the work we do. But we're not talking gigantic dollars. Even a large St. Joseph's Hospital has like $340,000 in their community benefits fund for everything. So it's nickel and diming. It's mostly passion and compassion and doing the work, labor of love kind of stuff. More money would be very nice.
So here's another question for you both. And I know, Barb, you've mentioned some work particularly that you've done in your county in this area, but so Phuong, you mentioned that the built environment has emerged in the CHA. And so what strategies in the CHIP are addressing this issue, and how can they be funded? So Phuong, I'm not sure if you have a response there. And I know, Barb, you definitely have something to say here based on some conversations that we've had with you in the past, but open it up to both of you.
Sure. So for Yuba County, one of its health priorities is a safe neighborhood and built environment. And it was very critical for us to think broadly about stakeholders. So we actually invited to the table Community Development Services Agency, which has public works under it. So we have some strategies around banning tobacco smoking, including vaping and smokeless tobacco in all parks within Yuba County jurisdiction. We also are fortunate to have the Blue Zone. So they're spearheading a lot of efforts about bikeability and walkability promotion. They have these walking moais that they've started within one of our local cities, and they're expanding to an additional couple of cities within Yuba County. But most of the time, it's also finding out what our public works colleagues, what our CBOs colleagues, even our offices of education colleagues are already doing surrounding safe neighborhood and built environment, and aligning all those efforts. So, yeah.
Well, you know, I don't mean to gloat, but our public works directors and our park directors and our council of governments directors are all part of our steering committee. So it's really a wonderful dividend for us. But in terms of what we're doing in our CHIP, because we want to focus on parks, we have what we call getting in the back door. It's called Safe Routes to Parks. So absolutely working on the built environment with lighting and safe pathways for bikes and walkers to get to the parks, but urban greening. So for the park piece, it works well, but our partners then do use the priority neighborhoods when they go after Caltrans grants to do work on walkability. Our Council of Governments, our COG, did a planning grant just in terms of what infrastructure was needed in some of our neighborhoods that are really, infrastructure is not very good at all. and got funding because they focused it as a priority neighborhood issue.
Thanks, Barb. Another question for you both. Could there be a requirement that communities serve in co-leadership rather than advisory roles in the child chips, as they have in San Joaquin, Sutter, and Yuba counties?
Hello, this is Michelle Gibbons. I'm happy to take that one with CHIAC. I think.
Great, thank you, Michelle.
Sure. I think the important thing to note is that there is a wide amount or a large amount of community engagement that goes into the child chip processes. I would also mention, though, that there's a wide amount of accountability as well, right? These are public things that they're putting forward about what the community is saying the needs are, the improvement plan to address those needs. And so jurisdictions on a routine basis are evaluating, like, where are we in that endeavor, and really just trying to figure out, like, are resources being invested that help to support that? Are we, you know, as we look at funds that come down as limited and constrained as they are they looking at that community health improvement plan to help identify how those funds are moving forward? I think some of them have, you know, like chair leads, things like that, that happen in that community health assessment and improvement plan process. But I will say that, you know, it really is a jurisdiction by jurisdiction space. And I would also just say that as we're expanding into, you know, partnering with different entities that may not have been our traditional partners before, I think there's going to be a whole host of new roles that continue to be explored and new partnerships. But I do just want to iterate, like, I have seen, you know, in our research on this, a tremendous amount of community engagement from a wide array of community partners as well. So it's not that we are just looking at like one area that a specific partner may be really interested in. There's a lot of community engagement. There is individual representatives, not just organizations. There's a lot of outreach that goes out to get people into these community forums, whether they're town halls and folks trying to support stipends or trying to draw folks. Childcare has been something that folks are providing. So there is a wide array of partnership that is happening in different structures in which that will continue to happen.
Thanks, Michelle. So Paul, going back to you, there are a couple of questions here. In terms of data, are race, ethnicity, and language part of the data to be exchanged, or will they come from a DHCS data bank?
So I think, you know, our plans and local health jurisdictions have different sources of demographic data. So I think, you know, we absolutely encourage everyone to be looking at health disparities locally. And I think that would be one of the conversations that plans and local health jurisdictions would have about, you know, what is the best source of getting stratified data to understand some of those disparities.
Thank you.
And excuse me, that's why I brought up the Healthy Places Index. If you're not familiar with that, that is the go-to Bible, so to speak, for health disparities. It's an amazing, amazing tour de force, layers and layers and layers on demographics of all kinds. Many health departments use that because it was during COVID, you had to say where your health quartile was that was having the most difficulty. So we're all pretty familiar with it on the public health side, but it's a Healthy Places Index.
Great, thank you. There are a couple of questions here about the gaps identified in the TRAs and what to do in the CHIPs, and where the plans come in terms of really supporting the CHIPs. Paula, do you want to speak at all to those questions?
Yeah, so I think as I alluded to, you know, obviously doing the assessment is step one. The point of the assessment is to then come up with a plan to actually invest and address those community needs over time. The current policy guide requirements that we are issuing are really on that step one of how is this assessment done. I think there is still policy development work we have to do for that step two, and what is the role of the plans in actually implementing the, you know, both the CHIP, but also the population health management strategy pieces that will be delivered to the department. And so we're still figuring that out. In the public comment and conversations we've had, we do obviously see there is a connection possibly between this effort and the community reinvestment requirements in the new 2024 Medi-cal managed care contracts, which will require all Medi-cal managed care plans that make a profit to reinvest a certain percentage of that profit back into the community. We are still working on policy guidance for that, so we're exploring what opportunities there are as well. And then I did see, I'll just answer the question while we're on it, Natasha, Deepa's question about whether you can submit one population health management strategy for all lines of business. And so plans are required to submit to NCQA sort of what your existing population health management strategy is per NCQA requirements. I will, if you are currently submitting one to NCQA for all lines of business, this policy does not change that. We will be having a state-specific additional requirement for the population health management strategy. That is the guidance that will come out next spring, which will be Medi-cal specific. And we are doing our best to not have it be duplicative with the NCQA submissions, but additive to those.
Great. There's a question here specific to Ventura County. And so Trudy, I'm not sure if you can be on to help with this question, and Michelle as well. But for Ventura County, we already have a collaborative CHNA and CHIP. The next CHNA would be published in June 2025, and then subsequently in June 2028. Since the CHNAs will be due by December 2028, does our current timeline work for this? The CHIP is usually published 4 to 6 months later. Sounds like it's on track, but Trudy and Michelle, just wanted to turn to you to make sure that's right.
Yeah, I think it is. I mean, the whole intent is to align all of the processes to that every 3 years. Our understanding is that for the majority of local health departments, the CHA process will normally take a year. And so that's why we included that December date. But if it happens sooner, I mean, I think that's great. And then you move into your CHIP process. But really, the intent is to align that 3-year process. So if it happens sooner, that's great. But the idea being that that CHA then really help the CHA informs the PHM strategy for the MCPs, and then they work collaboratively together around the CHIP process as well.
Thanks so much, Trudy. A question again to our public health colleagues, but in general for the CHAs and CHIPs, there's a question here about the engagement of tribal organizations in these discussions. And as Michelle mentioned, that these CHAs and CHIPs have deep stakeholder engagement in the community with a wide array. So do you want to speak to that? And Barb and Phuong, if you want to speak to that as well, but just on the tribal piece.
Yeah, I see Letitia is on the line. She's probably much more experienced on the requirements for FAB currently around tribal engagement.
Thank you.
Thank you, Trudy. So one important thing to take into consideration is that each local health jurisdiction is in different places. So accreditation requirements oftentimes get enhanced every several years. So there was a 2016 version, which we are currently working off of for our state health assessment and state health improvement plan. But when we reaccredit and create our next iteration of the SHA-SHIP, will be pursuant to the 2022 version. So that's one distinction to make clear. And then secondary to that, there's also a distinction around there's initial accreditation requirements and then there's reaccreditation requirements. So often if a local health jurisdiction is just pursuing accreditation, their requirements around a CHA and a CHIP will be different because they're mostly just supposed to be able to show that they have that collaborative partnership, they have a process in place. But when you're up for reaccreditation, they actually enhance some of those requirements because they really want to see how you're enhancing your CHA and CHIP to better understand the needs of the population, to address some of the emerging threats to public health, particularly like I had noted in the chat that for reaccreditation, they put an added emphasis around environmental resiliency. So for 2016 version, they actually used to specifically and explicitly call out that state, local, and tribal iterations of a CHA and CHIP should show how they align with one another. So we as a state would have to show how we were aligning to local community health assessments and improvement plans within our jurisdiction, as well as tribes, and then vice versa. Locals would have to show how they're aligning to the state and the tribes. They have since, in the 2022 version, pulled that explicit requirement out. However, it is still insinuated in a sense, and you are likely to be asked when the site visitors review your materials and such, you are likely to be asked, do you have tribal populations within your jurisdiction? How do you partner with them to advance these efforts? So it's definitely something that you should always consider, but just recognizing that the explicit requirement has been pulled out of the latest iteration of requirements.
Thank you so much for that. There was another question, Paul, maybe you want to talk about this, but will there be requirements on other hospitals, for example, for-profit hospitals, to participate in these collaborative efforts?
Yeah, I'll take that one. And then the related question around other lines of business. So currently there is no state or federal requirement over any hospital that is not a nonprofit hospital to participate in a community assessment process, and DHCS does not have direct regulatory authority over those entities. So I think, we'll defer to our public health colleagues. I imagine local health jurisdictions are reaching out to their hospital partners and encouraging participation, but there is no requirement. And then also, to be clear, for nonprofit hospitals, they have a federal requirement tied to, again, their IRS filings and their nonprofit tax exempt status to, perform a community assessment, the community health needs assessment, and then have a community benefit reinvestment program. There is no requirement of them to participate in this joint MCP local health jurisdiction process. So clearly some local communities in our state, the nonprofit hospital has been a strong partner and joined the table, but they are not required to do so. And then similarly on the managed care plan side, we hope that these robust relationships will result in our local health jurisdictions and managed care plans finding and taking advantage of all the creative ways in which they can partner to achieve mutual goals. But DHCS's policy will be limited to the medi-cal members because that is where our authority is.
Great. And I think we've Go ahead.
I'm sorry. In San Joaquin County, we have 7 hospitals. 6 of them are nonprofits. 1 of them is for-profit. We have 6 nonprofit hospitals who participate fully, and we do not have very good participation with our for-profit hospital.
Great. I think we've come upon most of the questions here. So should we open it up to our PHM advisory group? Does anybody want to come up, unmute, and ask any further questions? Are there areas that require further clarification or elaboration?
This is Catherine. Just one quick question. I think I might have gotten it in the slides. In terms of the draft language for the proposal, what's the turnaround time it's going to be released? And I know you've got to get something out by the end of this year or the first week of January.
So I would say, I think at this point, we are really trying to put pens down as quickly as possible. So if you have any feedback, I would say, please get it to us within the next week, if possible.
Absolutely. Thank you.
Any other questions here?
Sorry, just a follow-up to Catherine's question to clarify, this would be feedback just on the slides that we've seen today.
Correct. And then, as all of you have probably noticed, our population health management policy guide is a little bit of a living document because there's so many pieces that are evolving. And so we, as mentioned, that, there is going to be further guidance coming out next year. So any feedback that, for whatever reason, we cannot accommodate this go around, there will be an opportunity to deepen and further this policy as we continue conversations with all of our partners.
And just to clarify as well, at the end of this year, we'll be issuing a pre-release version of the guidance to MCPs, and then The full guidance will go up on the website at the beginning of next year, if that's helpful. Any other questions? There's actually one that came through the chat, Paul, and I think you already answered this, but it relates to NCQ accreditation. And so how does the PNA, the NCQ accreditate MCPs, have to submit for NCQ requirements fit into this reimagined PNA process? I think you've already addressed it, saying we're trying to align these processes as closely as possible, but not sure if you want to elaborate a bit more on that.
Yeah, and I will say, we're trying to clean up our nomenclature. We, the DHCS, have had a longstanding population needs assessment requirement, which is pretty robust and is now being morphed into this new PNA. The language and the standards that NCQA has, they use the term assessment, and it's part of their population health management standards. And that process is, I would say, globally more data-driven and not necessarily as robust and deep as what our old state-specific process was, or this new process that is being implemented. And so we are working with NCQA to really help develop a crosswalk to make these different, distinct requirements that we imagine are mutually synergistic, but not the same, very clear. So more to come on that, and we hope to get that out to plans and partners in the new year sometime. Any final comments from any of our advisory group? Okay, if not, we can give everyone a few minutes back. I just want to really sincerely thank both Barb and Phuong for just sharing your lived experience in this space, and really a huge shout out to CCLHO, CHEAC, CDPH, and HCI for just being wonderful partners to hopefully get us as a state to a future place where there's a lot of local synergy and alignment. So thank you, everyone, and we look forward to seeing all of you in the new year.
Thank you.